Bismillahirrahmanirrahim. Assalamu alaikum, the honorable guest speakers, respected nursing colleagues from TIH Karachi, Sheikh Sayed Memorial Campus, and outreach hospitals from Punjab, from Muzaffargarh, MIKD, and Badin, and all. Assalamu alaikum again, and a very good morning. It's my pleasure to welcome you all to the 6th Biennial ICON 2022 conference. We are grateful to Dr. Bari, the CEO IHHN, and Dr. Kashif Shazli, the head of the organizing committee, the members of all the other committees, and all the volunteers who have worked hard to arrange such a beautiful program. It is the first time the conference will be held virtually. The complete program is going on virtually and the conference is being planned from Thursday, that is today, January 20th, to Sunday, January 23rd, 2022. I urge all my nursing colleagues to kindly register yourself and to attend the sessions of your interest and to be part of the Pakistan's biggest multidisciplinary medical conference. The speakers in the program are uniquely placed to debate, discuss, and highlight the key points, trends, and reforms in the delivery of care by nurses, midwives, and other allied health professionals. It will be great to hear from our speakers about the influence and contributions by nursing at large and to highlight the frontline soldiers standing up against all the odds that keep coming in their way. I'm so sorry, we had some technical issues. So, last but not least, I would like to inform all the participants to receive the attendance certificate. Please fill out the evaluation form, which is a requirement to get the certificate. Thank you all. Now, for the programs, we have our three speakers, Dr. Raisa, who will be talking about challenges and creativity, teaching online in a practical discipline in Pakistan. Then Dr. Khairunisa Ajani, she will be discussing on nurses making sacrifices above and beyond the call of duty. And Mrs. Agnes Simon, who will be talking about Mrs. Duke Audrey, 17th century that changed the way obstetrics were taught. So, I will, before I hand over the floor to Dr. Raisa, let me give a brief introduction of Dr. Raisa. And it's my great pleasure to present the most inspirational nursing leader, one of the most inspirational nursing leaders of Pakistan. Currently, Dr. Raisa is working as a professor and dean at Shifa College of Nursing. Her career is spanned over 4 decades in nursing. She has held various clinical and administrative positions at the Aga Khan University Hospital, Shifa International Hospital, and the Aga Khan University School of Nursing and Midwifery. Dr. Gul has completed her basic nursing and midwifery education from Lady Reading Hospital, Peshawar, followed by a post-RN degree program from McMaster University, Canada, and a master's degree in health administration from University of New South Wales, Australia. She obtained her doctoral degree from the University of Alberta, Canada, and also completed her postdoctoral fellowship in the same university in 2013. Her research interest includes self-care behaviors and quality of life in patients with chronic conditions, critical thinking, and faculty development. She has supervised more than 40 students, graduate students at master's and PhD level. Dr. Raisa has more than 50 publications in national and international journals. She is a member of the Prime Minister's National Task Force on Health and a member of Islamabad Healthcare Regulatory Authority Board. She has been granted several awards in recognition of her scholarship, such as Discretion Fellowship from the University of Alberta, Outstanding Faculty Award from Aga Khan University Hospital, Aga Khan University, and a gold medal from the Khyber Pakhtunkhwa Nurses Association, and the State Award Pride of Performance. I welcome Dr. Raisa on board. And first, before Dr. Raisa comes on live, we will play the recording of her speech.
Bismillahirrahmanirrahim. Assalamu alaikum, and a very good morning, good afternoon, good evening to all the viewers in different parts of the world. Before proceeding to my talk, I take this opportunity to congratulate the Indus Hospital and Health Network on their 6th biennial conference on a great theme, that is Beyond the Call of Duty. I'm truly honored to be participating in this conference. Thank you, Ms. Rashida, the Director of Nursing at Indus Hospital. I concur with the organizers that COVID warranted efforts beyond the call of duty, but especially in the health workforce, in which nurses are at the forefront. So I acknowledge them and salute all the health workforce, but particularly my fellow nurses for their dedication and heroism that they display in this pandemic. Since I am situated in a college of nursing, one may think why it was an issue for us. Colleges were closed, students were sent home, and teaching was online. So let me share with you that this switch from traditional teaching to online teaching was not as simple for several reasons, which I will elaborate in a few minutes. I would like to share that this talk is mainly on my personal experience as an educator and administrator at Shifa College of Nursing, Islamabad. Examples shared are mine or of my faculty members or students at Shifa College of Nursing. Online teaching in this talk refers to both synchronous and asynchronous mode of teaching. Blended learning refers to a mix of online and face-to-face learning, which could be in a physical classroom or in a virtual classroom. This is plan of my talk. Switch from traditional to online teaching was challenging because we were not prepared for imparting education online. Thus, whether students or faculty, we were resisting. As one of the students said, and I quote, "When we went online, I felt totally blind." And personally, I recall my first experience in our leadership management course teaching online, that as if I am talking to a wall, because I could not see the faces of the students and their expression, but all I could see just my slide. I did not have the competence to manage the slides and also the student chat box. We did not have the skills to design online learning and assessment. We did not have the technical competence to manage online learning, and simply, as simple as managing a mic, as one to, turn it off and when to turn it on. A coherent or disciplined discussion without seeing the faces of each other looked like, a big task. Likewise, the availability of appropriate infrastructure. We had issued with computers, electricity, and internet. And this was not only related to the students. Even in our faculty, the issue was that faculty shares their offices. So when they all were teaching and teaching through computers for online teaching, we had an issue how to maintain their privacy, and how to prevent the interruption. So this was an issue. All the then existing policies, whether for teaching or assessment, were for physical face-to-face teaching and not for online teaching. So those policies were not working, and we had to constantly think through and keep it changing. Moreover, we did not have the evidence whether online teaching works in our context or not. Several students faced issue in their data collection. These were our MScN students. So we had to modify either their study design, population, or data collection. For example, a student wanted to see the questioning ability of the students, and the plan was that he will first look at the students who participate or do not participate. We wanted to take the extreme cases. But when the physical classes were not held and we moved to online, so the design required changing. We managed to do that, but it required thinking, changing, communicating with the IRB, and getting the approval again. So all of that was quite time taking. We felt like we will be left behind. Our biggest issue was the clinical practice. Initially, for maybe for a month or so, we thought that okay, the summer is going to come, so we will manage that. We will not have the summer break. But the thing continued, and it looked like there is no end to it. So and in that, it was not only the student parents who feared that the student will contract the disease. We had naturally the regulations that to keep the institution closed. And then the employers, they also, there were issues with the supplies. So, they didn't want to, they were not able to provide it to the student. And there was also fear that if they contract the disease, what will be the consequences. But overall, it looked like that we were experiencing change, and it is never easy to go through change. So how did we respond? Our initial response was to send the student home, and we created a WhatsApp for each class, each cohort for communication. Some faculty members, they went on leave because faculty members were also, several of my faculty members have young children, and, the children were at home. So, they were granted leaves to take care of their children, while other faculty members, they were required to help in the hospital. We were facing shortage of nurses at that time. So some faculty member went to the hospital to work there. And the management team, we started working on rescheduling, assessing that, what teachings is left, what was planned for assessment, and how we are going to do, because we were experiencing delays, in that. Also, the university management, they were, they tried to enhance the capacity of our internet, and also other supplies which were required to manage the online teaching, like the mics and all, because as I said, we were not prepared for it. But after a while, we we started building our capacity on blended learning. We understood that there is no way but to enhance our capacity, build first and then enhance our capacity for blended learning. Luckily, we had a professor from South Africa on our faculty who was prepared, who had a degree in online learning, and that was a great help. Along with him, other faculty member, we designed a graduate level course, which was quite comprehensive, and in which the faculty member who participated, they turned their courses for teaching through blended learning. In the same course, because we couldn't take all the faculty at the same time, so some faculty member took that course, as well as our graduate students, MSc students in the education track, who were coming from different colleges. They also took that course as their elective. So we enhanced not only our capacity, but as well as their capacity. And once we, continuing on that task, there was one point that, we were requested by our university to develop a short course, not as comprehensive as we did initially, but a short course, a 3 days course, to offer to all the faculty members in the university, and we did that. Then we received the request from a University of Venda in South Africa, to help them, and we offered a course for them. We then developed the capacity to redesign that course according to the learner needs. So we initially, it was an issue, but then with constant, I will say, motivation, constant effort, we build our capacity in blended learning. With further preparation and exploration, I would say our instructional processes were shifted from face-to-face to blended learning. We alternated our classes between the face-to-face and online from different years. Like if year one was in the college, face-to-face, because we wanted to keep up with the precautions of COVID. The year two was online, and likewise year three was in the school, so year four was online. So we alternated that, and then every 2 weeks, then we changed them again. In this way, by sending student home and teaching online, the overall population of the student was cut down, and the student who used to take their class, like my MScN class, who used to be in a small classroom, we shifted them to a bigger classroom, and again kept up with the precautions. We developed the learning communities. What it meant, that students were divided into small groups with pertinent instructions to engage in learning activities off campus, but using synchronized online platform. And then students were required to report to the teachers for evaluation and feedback. As I said, our bigger issue was managing the clinical skills. And I would say we were rather creative in that. So first of all, what we did, we segregated the skills based on whether they could be performed at home, in skills lab, or in hospital. For psychomotor skills, we developed the list of skills requiring use of specific instruments and supplies, and those who could be performed without any specific supplies or instruments. For example, thermometer or torch, soap, sanitizer, hot water bottle. These are the kind of things which are easily available at home. Teachers performed the skills, as you could see in this slide, that teachers performed the skill through live streaming, and student could see that and they could ask questions. And then the videos were recorded and provided to the students. So if there were students who could not attend it during this live streaming, they could refer to the video. Or if somebody wanted to see it repeated, they had access to that. Student demonstrated the skills at their home. Skills requiring specific supplies, such as insertion of nasogastric tubes or poly insertion, they were signed off in the small groups in the college. Skills requiring hospital setting, they were kept for the time. So whenever there was an ease in the lockdown, these groups were then called and they were signed off in the skills lab of the college. So this was for BScN students. Now for our MScN and post-RN BScN students, we were faced with another kind of challenge, because normally, and all of these students are registered nurses, but what happens that they all are not working in Shifa hospital. They were coming from other hospitals where they were, for their practicum, they were required to go to Shifa with certain objectives. And so in the normal days or before COVID, they would work there wherever they were working. And for their study and their specific clinical days, they would come to, they will go to the Shifa hospital. But during COVID, Shifa hospital developed and implemented a policy that any clinician, not only nurses, the nurses, doctors, technician, anyone who were working part-time elsewhere, they were not allowed. They finished, their contract. So because just for, contamination, they were not allowing people to come and go. So that was another issue. And for that case, though I tried, but it didn't work, because the policy was for everyone. So naturally, we had to look for a solution, and we changed our policies. So for example, we requested in the MScN case, we requested that is it possible that you continuously you work for whatever your work days are, and then in a block you take a 15 days leave, and then you can complete your the clinical objectives in Shifa hospital. For post-RN BScN, again, what we did, because they all are working in other places, so if their clinical facility was kind of if not exactly matching, but we evaluated if they could achieve their set objectives in their parent institution. We kept them there, and then had online Google meetings with them for post-conference and all, but they were able to achieve objective in their own hospital. But if their own hospital did not have those facility, in that case, we managed them in the same manner as we did our MScN students. Here, in this slide, you see that how students involved family members in their learning. They use them as simulated patients. And I think the positive side of that was that parents also got to know how their children are trained for skills. Student became very, very creative, as you could see in the picture on the right, that the student has labeled the bed with the hospital logo. They thought of alternatives. I was very impressed by them. Particularly, when the student did not have the hot water bottle, They did not just use any other drinking bottle to show it that as if it is the hot water bottle. What they did, they took uh, the the ketchup bags, which has very similar look like to hot water bottles, and it will have the similar features. So that was very interesting and very impressive, that how student also learned to think about the alternatives. So despite all the odds, we were able to achieve the planned goals for student induction, progression, and graduation. The only delay we faced was the final year BScN students who just, had to join for internship, I think 8 to 10 days delays, not more than that. So that is, I feel it's quite impressive, and alhamdulillah, I will say. In addition to meeting our set targets of induction, progression, and graduation, we prepared our faculty for blended learning, as I said earlier, in the college, for institutions, and also abroad for South Africa. So students also, learn, the graduate students learn how to deliver online, design and deliver, where the other student, they were involved in this experience. And as early, I said that the bigger issue is, not having the mindset. But I think now we have the mindset that yes, it can work. And now we have the evidence that it can work in our context. We also realized that if used well, it could be a good cost-saving strategy, like as recent as last month in November. I was supposed to have one examiner for our MScN thesis from England, and one from South Africa. But with the recent issue of the different strand of virus, the person from South Africa and also the UK, they could not obtain their visa. So we conducted all the thesis examination through online successfully. We also organized and conducted an online colloquium, which was earlier planned for that, we will do it with South Africa, but our faculty was supposed to go there and participate there. But because of, after the COVID, and because of our access and ability to do things online, we delivered that colloquium online successfully. So I'm certain that these achievements would not have been possible without working beyond the call of duty, because it was hard work. In conclusion, COVID confronted us with many challenges, but also presented us with many opportunities. It helped us to discover our potential and to solve our problems by using critical thinking, I would say. We had no choice but to think critically. We were forced to demonstrate out-of-box thinking. Usually you get to hear that, but we were in a situation that we had to think out of box. We couldn't just go the way we were used to. We were required to think proactively and plan everything. Like everything required not plan B, but plan C. If one doesn't work, we will go for this one, we will go for this one. So every action and every step required prioritization. I think through all of that, we learned to challenge our assumptions, and we learned the value of open-mindedness in a true sense. We made the use of reflection than ever before. At each step, we asked, did it work? Does it need a change? Can we continue in this way? Or we shall modify our approach. So COVID not only enhanced our critical thinking, but discovered our potential and developed our stamina to deal with uncertainties. Ladies and gentlemen, thank you very much for listening. I will be pleased to take any question that you may have. Thank you again.
Thank you so very much, Dr. Raisa. And it was such a nice presentation. I felt like I was part of the process, actual. So thank you so very much. I'll open the floor to the participants and we can take 2 or 3 questions if they have. Any question, please? Hey, Dr. Raisa.
Hello, Assalamu alaikum.
Walaikum assalam.
Yeah, I don't know. I even wrote a message that whether it is the recording or is it the internet over there or at my path. But
No,
you know,
initially we had few issues, technical issues, but then it went very well throughout the program. Yeah. So
all
do we
right.
have any
Okay.
questions
So
from
if
the
there is any
participants?
question,
Yeah. How would we take the questions from the participants if they have my IT team? Is it possible? So if there is no question, I would like to thank you so very much, Dr. Raisa, for your time and your patience. You have always been an inspirational leader for us, for me too, since I began my career. Thank you so very much. You can be part of our whole program because we will now invite another speaker, Dr. Khairul Nisa Ajani. Dr. Khairunisa Ajani is going to be on live, right? Hello. Okay. So before I give the floor to her, let me give a brief introduction of Dr. Khairunisa. Uh, uh, I feel pride, in fact, to introduce Dr. Khairunisa Ajani. She is one of the stars of Pakistan's nursing community, is an inspirational leader and role model for so many nurses who would like to follow her footpath. Dr. Khairunisa Ajani, she was very young, very choti si when I saw her in the program because, of course, she was in 1994, 5. When did you finish? At that time, well, of course, she was very young.
93.
So, and I could see her progress. Yes, her progress, her journey from a bedside nurse from in the ER to the assistant dean School of Nursing, Aga Khan University. So it's my pride, and we are really proud of you, Dr. Ajani. Dr. Ajani is currently working as an assistant professor and assistant dean of teaching learning undergraduate programs at the Aga Khan University School of Nursing and Midwifery. She is the first nurse to receive PhD degree in 2021 from her parent institution, which also makes her the first nationally prepared PhD nurse in Pakistan. So that's also a milestone that she and we all have achieved. Dr. Ajani's journey in nursing has begun in 1992 when she first time completed her midwifery, and then in 2021 she completed her PhD. That her degrees include diploma in nursing, post RN, masters, and things go on, I think, and it will go on, inshallah. Uh, Dr. Rajani provides support and monitoring for the delivery of academic programs at undergraduate level. She works closely with the TLNet, Dr. Rajani will explain TLNet because I personally do not know, and is one of the inaugural members of the Teachers Academy at AKU and a senior fellow of the HEA. Since 97, she has been working with Accusonum at various administrative positions and has gained a vast experience of working with all the academic programs. Uh, uh, Currently, she is coordinating and teaching education track of the Masters of Nursing program at the Aga Khan University, and for last 10 years, she served as a supervisor for the Masters studies. She has a number of publications in national and international journals and has been invited as a speaker at the national forums, many national forums. Her area of interest and work is around enhancing self-care practices, curriculum development, and engaging students as partners in the curriculum. In addition, Dr. Ajani also works with the Pakistan Nursing Council and higher education to bring about changes and innovation in the nursing curriculum at the national level. Uh, Last but not least, I would like to sincerely extend my gratitude to Dr. Rajani for accepting my invitation to be one of our speakers at very short notice. And I'm so happy and so proud of you, Dr. Rajani. I present Dr. Rajani to all of you for her speech. Thank you, Dr.
Um, Thank you, Ms. Rashida. Am I audible? And
Yes, you are.
all right, thank you. So thank you very much. I'm really humbled with that such elaborate introduction and for your gratitude. But it is as much my honor and my fortune that you invited me to be a speaker at such an elite forum. So thank you to Indus Hospital and thank you to your team for picking me. And I am also very humbled with the thought that I am speaking after my mentor and my thesis supervisor and my friend Dr. Raisa has elaborated. So I owe a lot to Dr. Raisa in my career, especially in the graduate and my PhD studies, and I always look up to her. So very humbled to be a part of this, and thank you for the opportunity. So I will try and share my screen. With everyone, and I will need some confirmation if this is visible. Are my slides visible to the audience? Can someone confirm?
Dr. Rajani, no, we can't see your slides, but hello, is it possible? हाँ वो शो कर रही हैं मगर वो हमें नहीं शो हो रही है. आप शेयर कर रहे हो डॉक्टर राजानी?
जी मैं
आपने
शेयर
शेयर
जी 1 मिनट दे दीजिए. ये नजर आ रही है?
Yes, yes.
Is it visible? Are the slides visible now? Rashida, can you hear me?
I think you can't hear me. Are you? Can you hear me, Dr. Rajani?
Yes, now I can. Are my
Yeah.
slides visible?
Yes. We can see your slides.
All right. Okay. So thank you again, and let's continue. And I apologize for playing around with this software as I'm new to this one. But let's go ahead with the talk. So I was requested to talk about nursing making sacrifices above and beyond the call of duty. So I will try and talk about these sacrifices and more so to the background stories or the confounding factors and the challenges that we as nurses in the area of clinical, in area of education practice, and in area of research face, and how these challenges and the confounders make us work beyond the call of duty, looking at the nature of the profession that we all are a part of, men and women, and what is the environment and what is the current trend and challenge around in the world and in the national relevant context, which calls us to go beyond duty, and how there are some sacrifices that we make. Should we be calling it sacrifice? Should we be calling it above and beyond the call of duty? And how can we now start to think as to how to preempt these challenges and how to professionally get together in our own different specialities and work towards preempting them and solving them? So I will try and do a next 15-20 minute discussion on this one. So let me begin with just reflecting on and reviewing as a nurse with all of you as my colleagues as to what actually is the nursing profession. So as described in the literature, in the evidence, and as basic as we can go to a level of the dictionary, nursing is a profession within the healthcare sector that focuses on care of individuals, families, communities, so that they may attain, maintain, or recover optimal health and quality of life. So we are an important part of the healthcare sector, and we do get that acknowledgement from the whole healthcare sector by being called the spine, the most important person, the frontline workers of any healthcare sector. Nurses play a very essential role in the society today by being advocates for health promotion, educating the public and patients on preventing injury, illness, and participating in rehabilitation and providing care and support. So, starting off with helping individuals, families, and communities to identify what their healthcare needs are in terms of not only treating them or helping them become better when they have the issues. Nurses also have a major role in helping individuals, families, and communities to preempting and identifying risk factors and areas of work that can help prevent future problems, prevent future complications, and severity of illnesses that can come. So, for example, identifying risk factors when nurses are working in the communities or in the hospital with families, with individuals, identifying issues like obesity, identifying issues like what diseases run in the family, how can nurses help families identify and promote self-care behaviors into the individuals and the family's own practices so that the complications and the incurrence of the disease can be delayed and its evidence can be controlled. So while I am talking about what the nursing profession is all about, I am also trying to emphasize its significance and its its importance in the whole arena of healthcare practice. We have grown up hearing that nursing is science and art. Caring is the focus of our nursing discipline. So, why is caring the focus? Why are we torn or kept apart of sometimes science and sometimes art? We are the focus of the healthcare arena in terms of enabling the patient, enabling the individual as a patient, as a healthcare seeker, and we become a part of the team which is providing the healthcare. So, healthcare, illness, deviation from wellness usually is not a very, very pleasant thing. There are some pleasant deviations like having babies, like having more better quality of life, but usually it is a point of stress. And so caring, being concerned, being compassionate, being thoughtful to the community, the individual that we are serving to, we become the core of enabling and empowering the patients. We have to, and to, in order to achieve that caring and thoughtfulness as a significance, we have to use the skills that are based on art. As the sculptor would look at shaping and giving a meaning to something solid, we as nurses are to and are expected to and should be using our knowledge base, our scientific knowledge base, to mold our intervention in a format which suits the other person who is here to seek the help. So we can't have a standard practice implementation chart. We may have three patients who have the same symptoms, but how are we going to educate them in their own reality, in their own context, in their own financial and economical structure is where the molding part will come, and we will be required to combine science with art. And so we become different from our roles from the other healthcare faculty members, being doctors, being physiotherapists, or pharmacists, that we can mold the education the patient requires, building on the knowledge that we have and using the art that we have to make it more contextually relevant. I couldn't emphasize more on how the nurses are and the role that they play in the healthcare sectors, as we are often described as serving on the front lines of the healthcare. We are the first to notice when a patient's condition has changed or to spring into action in a critical situation. And I think nobody can disagree here where we say that we are the actual front line who spend the most time with the patients, and we are the ones who are usually picking up clinical signs, picking up clinical symptoms to call in for the urgent help or to see if there is a change in the patient's condition, which could be better or worse, and take necessary action and plan the discourse and inform the other healthcare team members as to call for help or call for improvement when there is a change in the condition of the patient. So here some of the very important roles that we perform as nurses: caregivers, collaborators, educators, researchers, counselors. I can just go on and on with the list here, trying to define the roles that nurses provide and the variety and the diversity of roles that are entailed in one particular day of life of a nurse. And this significance, this background preparation, and the diversity of roles keeps adding to the demand of a nurse performing these roles, which keep changing from bed to bed. If you are an educator, the demand keeps changing from one class to the other, from one student to the other. If you are a researcher, the demand keeps changing from one area to the other in terms of the research process. And it is not that we as nurses or even doctors are expected to just perform one role and create your specialty. We all are working as nurses at some extent or the other, and then perform different roles of being educators at the bedside, at the classroom, doing researches at the bedside, adding to the existing knowledge, creating knowledge. And so the demand and the pull for our performance as a nurse keeps adding. The stress keeps adding and the demand keeps adding. So even if we keep aside the role that we are supposed to perform as women or men in our own families, in our own society, the profession itself entails a lot of demand because the healthcare needs are changing, the world is changing, and now the invasion of COVID from the past year, more than a year now. So that is adding to the demand of why the nurses feel those challenges and are pulled beyond to work beyond their call of duty. So let me try and touch upon some specific challenges that we face in terms of clinical area, in terms of education, in terms of research, which pulls us to the added demand. So, according to the WHO State of the World's Nursing Report, Pakistan faced a shortage of 1 million nurses even before the pandemic. So, shortage of nurses and allied health profession is described in the evidence to be one of the most critical challenges that the nurses are facing. And this shortage has kind of added on to the burden when COVID struck. So COVID came in, people went into quarantine, people went into isolation, people were required to be at home. There are many examples that Dr. Raisa also alluded to, that this has increased on the demand. So if there were already shortage and the ratio of the patient to nurse was already compromised, imagine when even those nurses who were functional and able to work were had to be sent because either their families needed them or they themselves had to be isolated and quarantined to be away from the patient. With that, lack of local institutes to prepare allied health professionals. In many countries, there is a lack of framework or a presence of professional councils for advanced health practitioners or allied health practitioners or nurses themselves. So the guiding body is unstable, there is shortage, and then there is a demand, extra demand posed on the need of the healthcare workers amid COVID. In education, I think the situation that the COVID has imposed, Dr. Raisa has very beautifully presented in her talk before me as to what are the challenges at the faculty level, the challenges at the student level, the challenges at the educational institutional level. And even if we were to talk about a situation which was pre-COVID or free of COVID, there are some challenges which are global and which need to be addressed in the best of time. So, educational digitalization. We all were forced to learn it, like Dr. Raisa alluded, that we were forced to do it because COVID did not leave us with much choice. And imagine if there is a shortage in the clinical area and the students would not graduate in time, the shortage would still become worse because the supply of the newer graduates would stop. So we were not left with choices. And now, with this millennial generation and the world moving towards blended hybrid learning and online learning, it is a demand that is posed to all educational institutions to be available, to add inclusivity, to add access, to be able to reach to people who want to connect online, live in far-fetched areas, don't want to leave their work, but want to attain higher education. So digitalization, inclusiveness, access to higher education, and then all this demands to the accreditation and quality framework from the higher education institutions, from the regulatory bodies, which will then guide the healthcare universities to be able to set up a system which balances online and face-to-face component, because in a healthcare educational licensure program, one cannot just teach online and not come to the patient and learn actually what needs to be done in the face-to-face component. Challenges in research. So capacity to conduct researches. How many of us nurses are actually trained and able to conduct, and we can count ourselves that yes, we have the capacity and the background to conduct research studies. How many of us have the opportunities to conduct the research? So many of us to attend to the call of duty amid COVID or before COVID or even in the near future. We are also pulled by the demand of the patient work that we hardly get time to connect, to conduct research study and create and pour out into the existing body of knowledge. We do not get that time. That is the challenge that we need to work out. We need to see how can we do that, because if we say that we are an important part of the healthcare sector and we are the ones who spend the most time with the patient, and if we do not get an opportunity to test out our interventions and to test out our knowledge with different practices that are available in other parts of the world, how will we add to the contextually relevant data from our perspective? And that can be done through evidence based practice, that can be done through research. Availability of grant to this part of the world. Because we do not have the correct qualification and higher education among nurses is limited. Now it has still become better than when we were looking for opportunities. But with higher education will come the preparation. And with the raise of the profile, we will be able to secure grants and conduct studies and then do publications. We have such limited number of good, reliable, valid journals and area to publish in, being from a lower middle income country, that we need to struggle to get that. So starting from the preparation to become a researcher and in order to conduct and then add and get this published is a major challenge on its own. Then I have this big list of confounders to these challenges. The challenges are there in clinical, the challenges are there in education, and the challenges are there in overall research practices. But apart from that, this list of challenges needs to be uh, confronted by every nurse that is working. Why are we why do we feel pulled to a call of beyond duty? Why do we need pulled and stressed, and there is high rate of burnout and physical symptoms in healthcare workers, especially nurses? It is because of this list of confounders that we have to face every day in all areas of our specialty. So, inadequate decision making power, there is a hierarchy in all healthcare programs, all healthcare arenas, because of its own causes that we need to identify in our own areas and work towards. Why can't we, as nurses, have our own management body and then go through the process that the other healthcare professionals go through and then devise policies around how we will define our work? Identifying specialities. Why are we still seen as somebody who stands at the bedside and that is what they know? If we go through a rigorous process of studying for 4 years like any other undergraduate, when are we going to stand up and say that we have as much knowledge as any other healthcare professional? Because we go through the same process. We have our licensing exam, we have our continuing education ideas, and we need policies around and framework around to show that to the world to be able to get a better image. Empathy of team members. We as nurses have to stand together and support each other and not identify what the other person is not doing, but identify what is our strength as working into groups. Lack of trust and empowerment in the collaborative process, lack of a clearly stated, shared, and measurable purpose. Why are we here? Why are we in this ward? What can we get together to achieve in this ward? How can we get together and achieve better in our own classrooms and our own research areas? Lack of training in interprofessional collaboration. I think that is a crux. Doctors have their own groups, their own study time. Everybody, doctors, nurses, pharmacists, they're all being prepared in their own parallel trails. And then in the end, they are expected to sit together, work together, and take care of the patient. But this is not a part of their training. So they don't even realize, including ourselves, that how to collaborate with other healthcare team members, how to talk to them, how to negotiate with them, how to have collaborative practices with them. Role and leadership ambiguity. I may be given a title, but how much power or how much preparation do I have to entail that power and designation? Lack of framework from problem discovery and resolution, difference in level of authority, power, expertise, our own traditions, our own norms and cultures that we have grown up with in medicine's history of hierarchy, especially in our context. And I always tell my students that in our context, doctor is after next to God. That is the level they have given out of respect because they are able to treat the patient. So whatever they can do, they don't have to struggle or they don't have to fight for their image. But nurses have struggled a lot to get the image and the recognition through scientific preparation and through their professional demonstration, and the struggle will still go on. So, how we carry ourselves, how we perform our duties, how we communicate with other people is a struggle that we have to check ourselves day in and out to tell the world that we are also refined professionals, and whatever the history entailed has changed to much of a difference now. Moving on now, talking about some solutions. So, to call beyond duty and to foresee the challenges, see, there will be time of disasters, there will be time of pandemics and epidemics, which will ask us to work beyond the call of duty. But there are some challenges that we have listed so far that we can preempt and make changes in our own capacities to enable us to control those challenges, so we are able and we are prepared better to work towards challenges which are beyond our control. So, things like collaborative trainings for nurses and doctors, by nurses and doctors. So, getting together and having interprofessional discourse and interaction while the nurses and the doctors are being trained will be the solution. When we are studying together in some courses, we will start to begin to realize what is their role, what is our role, what is everybody else's role. And so when we end up working together in education or in practice or in research, we are already oriented to what their roles are and how are they demanded to be working. COVID especially gave us a lot of opportunity to get us together. I personally know a lot of people in these pictures, but you as an audience will not be able to pick out a nurse from a doctor to a physiotherapist to a lab technician. That is the real picture of collaboration. COVID gave all healthcare professionals the opportunity to work together as a real multidisciplinary team in vaccination center, field isolation centers, teleclinics, hotlines, home health initiatives to control this pandemic, to enable the patient to take care of themselves, and as healthcare frontline warriors to control the spread of the disease as much as possible. This is the true crux of working together beyond the call of duty and foreseeing and working on the challenges from day one in order to achieve the maximum out of each other's roles. Another thing that worked was a good nexus and network between health and education. Dialogue with healthcare leaders and policymakers. What policies do we need? What support do we need from the stakeholders? How this collaboration between nurses, doctors, other healthcare team members can be strengthened. So these policy level changes and interaction will be the wall protection and the safety network that we get as nurses, so that we have laws around working, we have defined ratios to work around with, we have policies and support system, legal support, institutional support to be able to feel safe so we don't feel pulled beyond our call of duty. Also, working with allied health professionals. Now, nurses का role इतना ज़्यादा defined है that we are expected to do where in other parts of the world other people are doing, so that there is a little distribution of workload around the experts doing what they are supposed to do and not nurses filling in for everybody else. So role of the lactational consultant, role of the dental hygienist, role of other paramedics and allied health worker, which can take the burden off the nurse so they can focus on what they are trained to do and what they are supposed to do, and educate the role. Nurse's role as an educator, nursing role as a clinician, to pick up those changes and help the families and the individuals get better. Also, for our own sanity, we work in a stressful environment. Working in healthcare arena is very demanding because we are playing with human lives. We are talking about people's life and health impact on their life. So maintaining a balance for ourselves by committing to both professional and personal growth and relaxation is what we can choose. I should have the right to choose as to if I have the liberty of balancing my own life. My workload, my presence, my contribution at all times should be at a level where my own self care, my own mental health is not at stake, and I don't feel guilt of if I have sacrificed it all the time versus just once in a while. So, with that, I thank you all for your attention, and I am more than happy to answer any questions if there are.
Thank you so very much, Dr. Raisa, Carolnisa. I can see there is some questions been asked by people. One question I can read is, as you worked on different capacities, so how you see nurses outside AKUH?
I would say nurses are the same everywhere, dedicated and committed and extremely prepared. What we need to do, if you are asking me, especially outside the context of AKUH, is work on the different specialities of nurses which AKU supports. I would say in a better way compared to the others. Right now, there are many institutions who are looking at adding speciality to clinical nurses. So, adding advanced practice nurses role, which we initiated, and a lot of you are involved in working with us at the level of Pakistan Nursing Council, where we are struggling to look at higher advanced specialty roles in clinical. So, having nurses like lactational consultants, having advanced practice nurses in cardiology, endocrinology. So, you take up the responsibility of imparting knowledge to the patient at your own specialty level. Recognizing educators and educators, and both clinician and educators need to put in and plug in time for evidence based practice and research in their own capacities. So we need to voice out that this is a part of our job. Research, education, student education, patient education, this is a part of our job. And so even if we are working as bedside nurses, we should be getting preparation and the opportunity for collaborating with other healthcare professionals to conduct team care. Like we work towards the patient care model in a team, we work towards education, and we work towards research as well.
Thank you, Dr. Rajani. There are two more questions, and I quickly read it. One of them is a culture of self-sacrifice within the nursing profession may lead to job dissatisfaction,
Absolutely.
Burnout, and retention problems, especially for younger nurses. How we can deal with these issues?
So, very rightly pointed out, this is a very strong cause. And let's go to the reality. Why do we feel dissatisfied? Even as human beings, we will feel dissatisfied if we are asked to work more and we are rewarded less. So, आप अपना 100% दे रहे हैं मगर आपको 10% भी उसका reward नहीं मिल रहा, that is going to cause dissatisfaction. So the senior nurses, the leaders, need to pick up this conversation with the leadership of the institution as to defining policies and reward making processes in the system, that जो extra कर रहा है उसको उतना extra benefit mile, not only in terms of monitoring, but in terms of promotion, in terms of recognition, appreciation, sharing that extra work with the institutional level. So there can be many ways of rewarding. And till we get together as a group, एक छोटा सा unit भी अगर together होके एक application लेके जाएगा for their leadership to attend to their request of award and recognition, and also around policy कि ये इतना added stress इसलिए हो रहा है because हमारे patient nurse ratios ठीक नहीं है, हमारे patient sick बहुत हैं, we need extra help, we need other allied health professionals to come in and take up their role, so nurse is available to do what she is supposed to do. I think that kind of dialogue and policy structure needs to be worked at in order to control that dissatisfaction. Otherwise यही होगा कि जहां आपको better opportunity मिलेगी आप चले जाएंगे. And so many of our nurses, there is another comment that I'm reading, so many of nurses leave for abroad. Why do they do that? It is because they are not happy here. अगर उतनी ही quality of life यहाँ मिल जाए, उतना ही package comparable यहाँ मिल जाए, so who would want to leave their own country and go? They are forced to go because what they are getting here is not fulfilling their basic needs and their family needs. So these kind of discussion is imperative at the leadership level.
Thank you, Dr. Rajani. You have already answered to one of the questions that was asked about leaving the nurses abroad. So you have already covered that. And one question I can see which is important, I would like to know what one of the main competence apart from medical education would you like to be the part of nursing education by PNC?
I am not really clear with the question. I would like to know what are the main competence apart from medical education would you like to be a part of nursing? I am not sure, but nursing education needs its own recognition. So after so many years, in 2011, we came up with a nationally accepted curriculum. We have an undergraduate 4-year degree. We should now look at standardizing the master's curriculum, which is already underway. We should look at streamlining specialty advanced practice nurses role, which come from the Pakistan Nursing Council. So we are then able to run our own clinics as nurses, as nurse educators, and cater to specialty and patient care.
Yes.
If I understood the question correctly.
And I fully agree with you, Dr. Rajani. I think now we are running short of time, so I would like to leave it here. For the other questions, they can contact you when it's feasible, because we have to run another presentation. And before we run the other, I would like to thank you to Dr. Rajani. Now, next presentation is from Miss Simon. Miss Agnes Simon is a French midwife, and for last 8 years, she has served as the Vice President of European Midwives Association. And in September 2021, she has been appointed as President of the same body. In addition, she is serving as a senior manager and executive midwife coordinator, risk management at the Public University Hospitals of Paris for more than 11 years. She is an invited member of the European Fellow of Obstetrics and Gynecology Council. Miss Agnes is a globetrotter midwife for a French NGO, La Chaîne d'Espoir, in French Medical Institute for Mothers and Children, Kabul, Afghanistan, and coordinator of the maternity projects of the same or NGO. Miss Agnes holds a master's degree in risk management and has a passion in maternal and child care. Miss Agnes has also received a shared Nobel Peace Prize for being an active member of Medicine's Sans Frontiers. That is, in other word, is in English, it's called Doctors Without Borders. The award was issued to her by Nobel jury in October 1999. My huge pleasure to present the recorded speech of Miss Simon to you all. Just to make announcement that for question and answers, she is not available due to her other professional commitment at the moment. So we will just hear her speech. Thank you.
Hello, everyone in Karachi. I'm Agnès Simon. I'm the president of IMA, and I'm very glad for this invitation that makes me jump online, unfortunately, from Paris to Karachi. Today, I'm going to talk to you about a midwife who lived a long time ago, 18th century in France, but really still has an impact on how midwives are trained today, and you will see why. So Mrs. Angélique Ducoudray had a long life for the time. She was trained in the Medical University of Paris and very experienced in training midwife students. She even wrote a book about the art of delivery, and she was really, really proud of it because very few women were in the medical art, and very few women knew how to read at the time, and to publish book was even rarer. She lived in France during the reign of Louis XV and Louis XVI, and she died just before the French Revolution. Giving birth in 18th century France was quite a nightmare. And this is a picture in a well-to-do household, in probably a noble house, but you can see that the situation was a bit chaotic. You need to know that at the time in France, life expectancy for women was about 25 years, that maternal deaths, more than 1 out of 100 women died during childbirth, and 1 out of 4 children died before the 1 year old, and 1 out of 10 died before 10 years old. The training of the midwives in the 18th century France, very few midwives had a proper training. A few trained and experienced midwives lived in the city, but often midwives were ignorant. In the countryside, there was generally the fellow woman, the wise woman next door, but with no proper training. And there was a change of perspective in the 18th century. The loss of so many lives became intolerable. So Louis XV, the King of France, commissioned her to travel throughout throughout France to teach childbirth skills with the global goal of saving babies for the state. I mean, what was really a nonsense for the king that so many children that were a workforce for the country died at a very young age, or the mother died, and in his mind it was also a lot of future soldiers dying. So during 25 years she was on the roads. She trained 10,000 midwives. It was very incredible life, because if you think about the traveling at the time, about the bandits on the roads, about the cold, the uncomfortable situation. So she would arrive, she would be announced by an official letter of the king in small towns throughout the whole country of France. And locally, they will select a certain number of young women by a council elder that should be trained. and she would arrive and train with a few of help. She was not always welcome because the local medical power looked a bit with surprise and doubt to this very energetic midwife that had other ideas about how to teach uh, young women to become really efficient and knowledgeable women. So that's the new pedagogy she used. She had the idea to use simulation to train. And this pedagogy was really, really adapted to the students with all situation explained. As you can see on the picture, you can see a baby in the wound, you can see a placenta. She had really a mannequin for all the obstetrical situations. So there was, as we do now, an observer, a demonstrator, and a final practical examination. This is another view of the machine. You can be the baby, you can see the baby delivered, and now you can compare between the baby mannequin and the present baby mannequins. And I must say that when I was taught, the mannequin we had in the classrooms was pretty much like Madame Ducoudray's one, much more than like the new ones we have now. Look at today's machine. But the principle stays the same. You have the same, a mannequin, a simulation session, and you have observers, and then you have the feedback. And of course, now we even have serious game. I thank you so much, but do thank Madame Ducoudray that did change our way of teaching the midwives and the medical student as well. It was really the first real life experience, in fact, all our life, to teach midwives using the simulation process. I thank you very much. I hope you enjoy this Econ 2022 Congress, and I hope to go back to Karachi, where I've already been. Goodbye to everyone.
Thank you so very much, Miss Agnes. In your absence, we enjoyed the presentation, and for all who may wanted to see Miss Agnes, she was in white in the last slides of her presentation. So thank you so very much. Unfortunately, we won't be able to take any questions for Miss Agnes, as she is busy in one of her professional commitments at the moment. So she excused herself. I hope you all have enjoyed the sessions. Please do fill out the evaluation form to get the attendance certificate, because that is a mandatory requirement. Now, I would request Miss Rosina to come and deliver the vote of thanks speech. Thank you. Thank you, Miss Rosina. आप खड़ी हो जाओ।
Thank you, Ms. Rashida. Ladies and gentlemen, ICON Conference is an excellent opportunity to enhance our knowledge, gain and share new ideas and best practices, learn about the latest innovation, and to participate in professional networking, which will be utilized to deliver safe, effective care with positive healthcare outcomes. On behalf of the nursing services of Indus Hospital and Health Network, I would like to thank you all for joining us for ICON 2022. Your presence today shows a strong commitment and dedication towards learning. I would like to express my sincere gratitude to the executive guest speakers for sharing their knowledge and experiences with us. I trust that the participant will take home inspiration on how to foster the necessary changes through nursing professionalism, dedication, and compassion. I would like to thank organizing and event management committees who have worked very hard day and night to make this event successful. Lastly, I would like to express my gratitude to Dr. Abdul Bari Khan, CEO, Indus Hospital and Health Network, for providing a platform for sharing knowledge and experiences of our esteemed guest speakers. In the end, I congratulate each and everyone for the hard work and commitment that each one has shown during ICON 2022 and for making sacrifices during COVID-19 pandemic, especially at initial period of time. I pray to Almighty Allah to bless us and give us the strength to continue to serve humanity with honesty, dignity, and professionalism. May Allah subhanahu wa ta'ala bless us all with good health, wealth, and fortune. Ameen. Thank you.